Well, good afternoon, everybody. Y'all know who I am. Sorry, I know you don't, but unfortunately,
You
you probably
should.
get to know me. I'm David. I'm one of the hospitals here at MCMH. And a few months ago, they asked me to put together just a basic ECG reading and interpretation class for nurses, for staff, or anybody that wants to come and check it out. So I put together a little class, mainly just to kind of, a lot of this to you guys will be review, but some of the concepts in regards to how to read an ECG rhythm strip and different ways to do it, you may or may have not been taught this over the years. I've been a nurse for right 30 years. This is part of our basic curriculum when I was in school. And I've heard from many of the newer nurses that this just isn't taught anymore.
You just get over cardiac very fast.
That's kind of what I've heard. So I hope I don't bore you. You're going to see a lot of stuff that might be review, but I figure if we're going to talk about, how to go through a rhythm strip, we need to review the anatomy and know how the heart works and what it does. So welcome. I'll try to keep you, an hour or under. So what are we going to talk about today? So we're going to talk about what an ECG is. ECG, EKG, I'm sure you've heard that interchangeably over the years. Its definition of purpose. We're going to talk a little bit about basic anatomy of the heart. We'll just talk about the electrical conduction system of the heart, the SA node, the AV node, the bundle of His Purkinje fibers, and the right and left main bundles. We'll talk a little bit about the electrical conduction and then a normal electrical pathway. So what is an ECG and what does it show us? Well, an ECG is simply a non-invasive test that measures the electrical activity of the heart and shows how it's beating. It's completed by attaching electrodes to the chest, arms, and legs, and then it's connected to a machine that records the heart's electrical activity. And this can be done in many different ways, of which we'll talk about here in a little while. But that's mainly what an ECG is looking at. So let's go back to the basics. Anatomy Physiology 101 from the start of nursing school. Here's just a cut down the center of the heart. You see the two upper right atrium, or the upper right atrium, left atrium, the right and left ventricles, and just the basic anatomy of what the heart looks like. So this slide kind of talks a little bit about the heart and its function. You've got the superior and inferior vena cava, where the deoxygenated blood comes back into the heart on the right side, goes into the lungs via the pulmonary arteries, exchanges gas at the alveoli level, sends oxygenated blood back to the heart into the left side, and then it's pumped out through the aorta throughout the body and throughout the system. The heart's about the size of your fist. Some people's a little bit bigger than the fist, some people about the size of the fist. Obviously, you've got the two upper chambers, the atria, the two ventricles, the lower chambers. And you've got three valves, the tricuspid, bicuspid, and the aortic valves. And these permit blood flow in only one direction, which is truly the case, but as people can get older, you'll develop some valvular troubles where you'll sometimes have blood leak and cause more problems, but that's more advanced stuff that we won't talk about today. The heart pumps about 5 liters of blood through the body every day. Its purpose is to pump oxygen, poor blood from the right side of the heart to your lungs and back out to the left side of the heart through the body, delivering oxygen to the cells and tissue. And its typical normal rate is 60 to 100. And that can vary from a little bit from here to there. Any questions about anatomy? This again is just a bigger picture of the pathway of the blood through the heart. One thing to note is as blood comes into the heart, it's regulated by how it flows by pressure gradients as you're going through diastole and systole, which we'll talk about here in a minute. But this is just kind of a better depiction of how the blood flows through the heart and the vasculature out of the body. So the conduction system of the heart. I think I've always liked cardiology as I got into the nursing profession. It's complicated. There's basic things about it, but it can be also complicated. But I think the heart is a really cool organ because of characteristics that the heart has that no other organs in the body has. And there's four main parts of the heart that are important when it comes to the cardiac cell. Cardiac cells are called cardiomyocytes. They're striated muscle cells like skeletal muscle cells. They're branched, which means they're interdigitable, so they work more efficiently, they work together. But there's 4 characteristics of the cardiac cell. What's the one, I'll ask you guys if you know this answer. There's one function that a cardiac cell has that no other cells in the body has. Do you know what that function or characteristic is? You'll probably know when you hear me say it.
Conduction, like electrical conduction?
Yes, it does have conductivity. That's one of the 4. It can conduct rapidly and efficiently. But there's one thing that makes cardiac cells completely different that takes it out of any other cell in the body. It's called automaticity. Cardiac cells have automaticity, and what that means is each individual cardiac cell has the ability to fire an electrical impulse on its own if, for some reason, it senses that the sinoatrial node isn't sending a signal. Your cardiac cells, all of them do, and all of them they have the ability to act as the natural pacemaker if they need to. And so automaticity allows the heart to continue to be able to work even in the event that you have damage to one of the primary nodes. So that's what I think is pretty cool about the heart, is the automaticity and the fact that you can have damage somewhere, but one cell in the heart can pick up and take off where the others can't, and you'll continue to have beats. Now, will they be a normal beat? If you got to the point where you have to have a cardiac cell fire, there's something wrong. But it is cool that it has the ability to do that. Another function about the cardiac cell is its excitability. It can respond to electrical stimuluses obviously from the automaticity, and then the conductivity, which we talked about. And the last one is contractility, and it's capable of both long and strong contractions, which is obviously essential. As we exercise, we get the heart rate up, the cardiac output increases. The heart has to have the ability to adjust to the workload that is under. So that's the kind of the makeup of the cardiac cell, the myocyte. So if you look at the conduction system of the heart, you've got the sinoatrial node that sits in the upper portion of the right atrium, and that's where everything starts in a cardiac cycle, is the sinoatrial node. It typically has a pulse rate of 60 to 100 per minute, and that's where your electrical conduction starts. It then travels through the atrium, meets back up at the AV node, and the AV node then transfers the electrical signal down through the bundle of His, which is down the septal walls of the heart, and then out to the Purkinje fibers in the right and the left main branches. So when you see EKGs or you read EKGs and you see right bundle branch block, left bundle branch block, that's referring to the main right or left bundle of the heart, and something has caused it to be blocked. Do they have ischemia from an MI? Do they have a genetic disease that's caused an issue with the electrical cycle? Do they have an aberrant pathway where you've got some funky electrical pathway that some people have and some people don't, and it's causing the branches to be blocked? Those are just some of the different things that can happen causing different issues. But that's how a typical conduction cycle happens as it fires through the heart. This is just another picture of the cardiac cycle. And as you first go through cardiac diastole, where all the chambers are relaxed and the blood flows into the heart. As the electrical signal fires, and it fires through the atrium, and as it does that, a lot of pictures will depict when it hits the sinoatrial node starts, it kind of goes out like I don't know what you'd call it, like fingers. I was always taught that when a sinoatrial node signal goes out, it's like a tornado. And it wraps around all the atrium, fires through the atrium, and then comes back to a single point at the AV node. Then the AV node picks it up and then transmits it through the rest of the ventricles like a tornado until it ends in the bundle branches. After diastole, you go into atrial asystole, or atrial systole, and ventricular diastole, where the atria contract, pushing blood into the ventricles. And what happens is, as blood, obviously, your atrium and ventricles are working to keep blood flowing. And it's all based on pressure gradients. As the pressure gradients reach a certain point, the valves open and blood rushes in. So as the ventricles pump and you reach the right pressure gradient, blood will be let into the atrium and the cycle just continues. And then finally, you hit atrial diastole and ventricular systole. After the atria relax, the ventricles contract, pushing blood throughout the heart and sending oxygen to the tissues. So any questions so far about that stuff? Anatomy, physiology, electrical conduction? If you're thinking of something or have a question, feel free to ask. So, my computer will work. This is what we want to see when we look at a strip. This is a normal sinus rhythm. It's got P waves, they're upright, they're symmetrical, you've got a normal PR interval, you've got a QRS complex followed by a T wave, your rates, me looking at that rate, I'd probably say it's 70, 75. So that is what we want to see. Do we always see that? Not always. And so that's what we're going to talk about more of. So this is the PQRST complex. This depicts on what happens during this time. So everything starts, you get the electrical conduction that comes from the SA node through the atrium, and that's what triggers the atrium to contract. And this is, so you've got your P wave, the atria contract, you've got your PR interval, you get the electrical impulse down through the ventricles, you get your QRS complex, the ventricles contract, which is up to the T wave, and then you're back to atrial repolarization. It's just a constant motion all the time. You have a constant cardiac action potential where you've got sodium and potassium flowing through the cells, which is what triggers the electrical impulse, which triggers the cardiac cycle. The cardiac cycle and action potential itself is a very complex system, but we're going to keep that simple in this class. This is just another depiction of the PQRST intervals. We've kind of talked about it, so this is just another slide to kind of show you what it looks like on a strip as what's happening in the heart. So, why we're here? Let's talk about ECG, EKG equipment. So we're going to talk a little bit about machines, 3 leads, 4 leads, 5 leads, 12 leads, proper lead placement, limb leads versus precordial leads, and then 10th fracture placement. As I did this class and first started to teach it, the first 2 classes, I realized some of these I wish I would have put in different orders, so I apologize if some things seem a little bit out of order. So, ECGs, standard monitoring systems, and what we see. So, the standard 3-lead bipolar monitoring system, you don't see these much anymore. When I started in nursing and EMS 30 years ago, 3 leads were about all we saw. In the field, we had 3 leads. Hospital telemetry units for 3 leads, but technology has just moved along where 3 leads are almost dinosaurs anymore. But the 3-lead system is a bipolar recording between 3 leads using 2 leads at a time. It's the most common type of telemetry monitors, but it's much less detailed than what we would see in an ICU in a hospital monitoring system. There's 4-lead systems. You'll see 4 torso limbs, right arm, left arm, right leg, left leg, with a lead as a ground. A lot of the hospital systems and EMS systems, we're using these now. A lot of the EMS units are 4 or 5 leads now. Our telemetry is probably, 4 or 5 leads now? 5 leads. See, that's standard anymore.
But pre-op in Jennings, I think they run a 3.
They run 3.
They still run 3
Yeah.
leads. So they still exist, and they definitely provide function. It's just you're getting fewer details. Ultimately, the more leads you add, the more angles of the heart you're looking at, and the more information you're going to gain. And so it just depends on how much information you want in whatever unit you're working in. The 5-lead monitoring system has 4 torso leads plus a chest lead, which provides better anterior heart view. You see these in enhanced monitoring with limited electrodes, and then you'll see these in ICU units and anesthesia monitors. And then obviously the 12 lead, which is what we really use to identify problems, injury, electrical conduction issues. We're not going to talk about that in this class because 12 lead interpretation in itself is very complex with a lot of different things. So I may put together a class on that down the road, but we're not going to talk about that today. Just a picture of somebody having an EKG done, and you've all seen this. So ECG placement. Yeah, I'm sure you've all heard the smoke over fire, white is right. I was taught smoke over fire, white is right. The green grass grows underneath the clouds, and then the brown lead was always the chest lead. That's how I was taught. I don't know how you guys, or were you guys even taught that mnemonic?
I was.
Yeah.
I rolled.
Yeah.
I just did it.
This
Right
is-
arm,
this is-
right lower,
Black grass
left,
under cloud.
left arm, left lower.
I hate to say this, but
I like
I've been doing this 30 years now, and if I'm putting leads on, because I still am on Tabor's volunteer ambulance and function as a paramedic still, I have to tell myself as I'm putting leads
do it
on, why don't you ride? Just it's just
You
happening.
gotta remember how you're
It's
looking at
happened,
it.
exactly.
It's not your right, it's their right.
Yeah. Oh, yeah. Exactly. So that's pretty much, if it's a 4-lead system, you eliminate the chest lead. If it's a 3-lead, you eliminate the chest lead and the right leg. So it's just whatever you're using. Any questions about lead placement? So,
Well, I do have a question.
yeah.
For EKGs, does it make a difference if you put their leg leads up here? Like, how much of a difference does it make?
Not too much. The biggest thing you have to worry about with lead placement is you want to avoid large muscle masses because it lowers conductivity. I don't know, Lauren probably has more experience with this in the cath lab. As far as fatty tissue, does that impede conduction?
We always would put them down basically on the shin bones.
All the way down on the, yeah.
Keep it away from the muscle and the fat and things like that, just so you don't get interference.
I mean, you can put them up high. You're just not going to get as good conduction as you would if you got to a smaller area of muscle volume. So the answer is kind of yes, you can, but it just depends on what information you're wanting to get out of it.
Plus, if they're really bony, it makes a
Yes.
difference too.
Yeah,
Trouble
exactly.
ER with some larger people even getting them to read at all.
Yeah, exactly. You deal with artifact and everything else. So where did the ECG start out? So we're not going to get deep into this, but the ECG actually came into fruition a long time ago. Back in 1900, William Einthoven, he developed the first ECG monitoring system. And in 1901, he developed the string galvanometer, and this allowed for a weak recording of electrical pulses in the body. And this is what led to the first ECG machine. And his premise is the Einthoven's triangle. And what he developed was an equilateral triangle with the heart in the center of the chest, and it takes bipolar recordings of the 3 leads. And you've got lead 1, which is the right arm to the left arm, lead 2, which is the right arm to the left leg, and lead 3, which is the left arm to the left leg. And this was utilized to help us understand the heart's electrical activity from different angles. And this is where we get the different wave deflections. If you're moving towards an impulse, you have positive deflection of the wave. If you're moving away from an impulse, you'll have negative deflection of the wave. This was such a huge finding back then that in 1924 he won the Nobel Peace Prize for medical sciences and physiology. So if it wasn't for Einthoven, I don't know what we'd be doing, if we'd even be considering this today. So that's just some basics about where the ECG came from. I'm going to talk very briefly about axis reference system. This gets big into 12 leads, and I think the axis system is complicated, and it's what it is the sum of depolarization vectors by individual cardiac myocytes, and clinically is reflected by the ventricular axis, and interpretation relies on the relationship between the QRS axis and the limb leads. And so the normal axis is anywhere from minus 30 degrees to plus 90 degrees. And depending on the person, the problems, it can shift. You can have some right axis deviation, left axis deviation. I'm sure you've all seen that on EKGs. A left axis deviation is anything less than the minus 30 degrees. Right axis deviation is anything greater than plus 90 degrees. And typically, the heart has a downward and slightly left axis deviation because the left ventricle is the largest part of the organ. So it just has the tendency to kind of pull that way. So as we go along down the road, and if we do more advanced classes, we'll get more into the whole axis reference system. But I just want to kind of just throw it out there just so you understand that this system does exist, and the cardiology uses it a lot in determining problems and issues patients might be having. So this is just a quick slide for tips for ensuring an accurate ECG. Make sure the skin's clean and dry. Make sure if there's chest hair to shave it. Make sure you have good contact. Make sure the leads are on flat skin and avoid large muscle groups, which you talked about. Make sure the patient's relaxing in supine position if able. Place the limb leads distal to the shoulder and hips, but not on the wrists and ankles. Although I think a lot of people put them on the ankles and wrists. I mean, you really are lowering your amount of subcutaneous tissue and muscle tissue to get good conduction. And then ensure machine wires are not frayed or worn. And then make sure you apply the electrodes by pressing around the edges, not the center, to avoid developing air pockets. EKG leads can be a pain in the butt getting the patches on. You know, you tear the cover off and then try to put it on the lead, and it sticks, and then it bunches up, and then so I always try to put them on and then peel them off when I put them on. But do whatever works. That's a minor thing. So reading EKG strips, your ECG strips. We're going to talk just briefly about ECG paper, grid layout, timing, voltage measurements, kind of a little bit about basic components of an ECG, EKG, and then we're going to talk about the different aspects of a PQRST complex. Any questions thus far? I know I'm kind of moving along kind of quick. So ECG paper, all of it is about the same. It's all thermal paper. It's heat sensitive, and the actual rhythm strip is printed using heat. And you have pre-printed grid lines for measurement and interpretation. A lot of the new machines use Z-fold paper, and it's just easier to handle. I don't know, is ours Z-folded, or ours come in rolls in our system?
Yeah, I think the machine.
In the ER, I think they're folded.
The Zoll machines are Z-fold.
Yeah.
I don't know about the others.
The mind rays
I guess I don't
are
know.
rolls.
Rolls,
honestly.
yeah.
Yeah.
So this is just something to know in regards to EKG paper, because it's different than any standard paper that we use. So ECG grid and layout. So your horizontal line is your timeline. So this is looking at one large square on a piece of rhythm strip paper. Large square, horizontal axis is time. Each tiny square is 0.04 seconds. One total large square is 5 millimeters or 0.2 seconds. Your vertical axis is your voltage in millivolts. Each small square is 0.1 millivolt, and 10 millimeters equals 1 millivolt. A large square is 0.5 millivolts. So that's just your basic reference of how you're going to measure when you're actually doing a rhythm interpretation. So how do we go about evaluating an ECG strip? We're going to talk about different methods of how to measure and figure out rate and that kind of thing. But these are the things that you need to look for when you're doing a rhythm interpretation. First is identify and examine. You're going to identify and examine the P waves. Are they present? Are they upright? Are they symmetrical? Do they look the same? Is the interval between 0.06 and 0.12? I was always taught 0.08 to 0.12, but 0.02 seconds isn't that big a deal. Measure the PR interval. Count the small boxes from the beginning of the P wave to the peak of the QRS complex. Multiply this by 0.04. Normal intervals between 0.12 and 0.2. Now, we had some discussion about this in our earlier classes, that if you, technically, to measure a PR interval, it says to go to the peak of the complex, would be the R wave, which is the PR interval. But a lot of times people measure from the beginning of the P wave to the beginning of the Q wave. And so, what's that?
That's how it says. to me.
Right, exactly. But technically, you're supposed to measure to the peak, which could be, you could see a lot more first degree blocks if you're measuring all the way to the peak on the R wave, because that's technically the peak of ventricular diastole, ventricular depolarization is the peak of the R wave. So there's some semantics in that, but
Should be Jenny.
I'll probably still measure it the same I always have, which is from the beginning of the peak to the Q wave. What's that?
I said, so which is it?
I was just like, do I need to order different cards?
No, I would do like the card says, because honestly, that's how most people measure.
Well, I've been
But from a
That's how I've
definition,
always done it, but-
from a definition, you're supposed to measure to the peak, which is the
Should
R
be the
wave.
PQ.
I started
It should be the PQ interval.
Yeah.
I mean, realistically. So,
I started measuring to the
Especially
R
for us
and
people
was
that are
corrected.
what's that?
Yeah.
I just do the PQ because it
I-
just,
Me too. I'm the
honestly,
same
it
way.
doesn't change much.
No. And then after you measure the PR, measure the QRS complex. Again, count the number of small boxes from the beginning of the to end of QRS, then divide by 0.04. This should be between 0.06 and 0.12 seconds. Now, this step I usually do first. I usually identify first. I try to identify the rhythm first because I always like to look at the R to R ratio as my first identifier when I'm doing a rhythm strip interpretation. So you could start with the P waves, or you could start with the R, looking at the R to R waves, because that's going to help you assess whether it's regular or not. So again, that's totally preferential or personal preference. So identify the rhythm, assess for regularity, the R to R ratio, the R to R interval with or without a pattern, and patterns should be consistent or inconsistent. And then determine the heart rate. There's multiple methods you can figure the rate: the big box method, the 6-second method, and the square counting method. I'm going to show you them all, and then you guys can decide which one you want to use. I know now these machines count it all for you, and they'll even they'll even measure your intervals for you. But we'll just kind of show you the basics. So, P waves. P waves record the electrical activity through the upper chambers of the heart. If they originate in the SA node, they're less than 0.1 seconds long. They have an amplitude of less than 0.25 millivolts in the precordial leads and less than 0.15 millivolts in the limb leads. Disperses in both right and left atrium, and lack of P waves may reveal signs of dysfunction, fibrillation, or flutter. So that's where I talk about it disperses in both atrium, where it disperses like a tornado and it wraps around both atria at the same time. The PR interval is the time from the beginning of the P wave to the beginning of the QRS complex. See? It already contradicts itself. So I'm glad somebody pointed that out to me this morning because I hadn't really been paying attention. I'm like, yeah, you're right. Reflects the conduction velocity from the AV node through the bundle of His in the Purkinje system. Indicates health of the AV node, which is important in rate regulation. Helps diagnose AV node conditions such as heart blocks and arrhythmias. And this is something I forgot to mention when I was talking about physiology earlier in conduction systems. This is important because without the P wave, that means your SA node isn't firing. Well, your AV node and then your bundles and your branches, they conduct at a much slower rate than your sinoatrial node. Your sinoatrial node will conduct at 60 to 100 pulses. Your AV node will conduct from 40 to 60 pulses per minute, and then on down is 20 to 40 to 40 to 60 pulses per minute. So you're going to know you have an issue is if you have no P waves and your rate is slow, you have an SA node problem, probably. The QRS complex records the electrical activity through the lower heart chambers, represents ventricular depolarization. The QRS complex is 0.12 seconds long, and you'll see upright and inverted deflections of the Q, R, and S. So your Q and your S wave will be negatively deflected, and your R wave will be positively deflected. A long QRS may indicate an interventricular conduction delay. Now, something to note is you may not always see a Q wave. Everybody's a little bit different, so you may not always see a Q wave. T waves. And I'm not sure why I have it in there. Forget the atrial repolarization. T waves record the electrical activity through the upper heart chambers, but it really represents ventricular repolarization. A positive T wave indicates normal ventricular function. Changes in T wave morphology may indicate ischemia or electrolyte imbalances, and always follows the QRS complex. Always. You should always have a P wave before a QRS complex. You should always have a T wave after a QRS complex. What are some things that we look at when we look at T waves? That's
The elevation.
yes. And what is something that we usually can identify by T waves?
STEMI.
STEMI. What else? What if you have really high peak T waves? What does that indicate?
Is that something with the math?
High potassium.
Not mag, potassium.
Potassium.
High potassium. Hyperkalemia. If you have significant hyperkalemia, you'll see high tall peak T waves. So that's something you can always look for. Any questions about the PQRST? So the QT interval. QT interval is important, especially with different medications that we utilize, different antibiotics, different antifungals, how medications interact with each other. This is something that you need to pay attention to. The QT interval is the time between onset of depolarization and the termination of repolarization. It starts at the beginning of the QRS and it ends with a T wave returning to the isoelectric line. A prolonged QT can lead to lethal arrhythmias and is caused by electrolyte imbalance, medications, infections, hypothermia, and left ventricular hypertrophy. It can also lead to torsades de Puentes. So, the normal QTC in men and women is a little different. Normal in a men is 470 milliseconds, women is 480 milliseconds. When I look at a 12 lead and I'm looking at a QTC interval, all I look for is to see if it's less than 500. Sometimes it's just hard to remember numbers, and if you just remember, you want your QTC interval less than 500, you're safe. Some medications will slow the time your heart takes to recharge in order to make the next electrical impulse, leading to the next heartbeat. And if it takes too long, it might skip a beat or could throw you into a lethal arrhythmia. So it's something that you just want to pay attention to. All right, here we go. The large square method. Now this is the old school method that I was taught when I was in nursing school. Everybody looks at this now and they're like, what? So the large square method. So pretend that you have a rhythm strip that's a minute long, a full minute of strip. So in 1 minute's time on a strip, you're going to have 300 large squares. If you have a minute strip and you're looking at your small squares, you're going to have 1,500. That's where your conversion factors come. Your 300 and your 1,500. So the large square method is one large square is 300. So if your R to R intervals are 1 square long, you have a heart rate of 300. You have a problem. You have a significant problem. If you do 2 large squares, you take 300 divided by 2 is 150. Obviously, you go to 3 divided by 3, and that's how you can determine your rate. Your large squares, that's using the large squares. Your small squares, you would just take 5 up to 10, 15, and divide them out. Now, I was taught with a modified version of this. I was taught to count your R to R intervals and then just count from 1,500, 300, 150, 100, 75, 60, 50, 43, 38, on down. Have you heard of that?
No.
Okay, so Lauren's heard of it. There's a lot of people that have never heard of that. That's how I was taught.
Back before they invented math.
Yeah. So not a lot of people use this method because you have to kind of think about it. And if you're not used to doing it, the conversion kind of can confuse you. So a lot of people do the 6-second method, which is what we're going to talk about next. This is easy. You identify your QRS complexes on your ECG strip with 30 large squares. Count how many QRS complexes or P waves fall within the 6-second interval. You take it times 10, and that's your rate. Now, you have to take it with a bit of a grain of salt because this is based on a regular strip. So if you get an atrial fib that may have a rapid ventricular rate, your rate may not be quite as accurate because it's a bit irregular. So I think this is the easiest method to do it, other than using your computer readouts. But just realize that if it's an irregular rhythm, it may not be quite as accurate as you want it to be. So, but this by far is the easiest method to figure out the rate of a strip. So we're going to talk about some normal and abnormal rhythms. We're going to talk a little bit about normal sinus rhythm, characteristics and significant, common arrhythmias, atrial fib and flutter, VTach, VFib, and then some bradycardias and tachycardias. So, normal sinus rhythm. This is the one we started with. This is what we want everybody to be in. A normal heart rate, regular symmetrical P waves, they all march out the same. You have a normal QRS complex with normal deflection. You have a T wave following all your QRSs. Your rate is controlled, means that everything is working lovely. Sinus bradycardia. So your heart rate should be less than 60. You have a normal rhythm origination from the SA node. Your P waves are upright and consistent. Your QRSs are normal in shape and duration. You have a normal PR interval of 0.12 to 0.20. Your T waves are upright. You may see this in athletes. People that exercise, they can become very bradycardic. However, you may also see people that have issues with their AV nodes or that is causing their rate to be low. Ultimately, the best way to think about bradycardia is if you're having patients that are symptomatic, you need to find the cause and treat it. Because most times sinus bradycardia issues are related to something other than a cardiac dysfunction. Sinus tachycardia. Heart rate is greater than 100 at rest. You have a regular rhythm, normal P waves, normal QRS complexes, usually caused by stress, fever, anemia, hypothyroidism. Can be transient or persistent. And again, just like bradycardia, if it's symptomatic, find the reason why and fix it. A lot of times we see sinus tachycardia in the older population. Most elderly people, when they come in to be seen and they're sick, they're already 1 to 2 liters low on fluid because they just don't drink, they don't feel like it, and a lot of them will have sinus tachycardia. So you replace the fluid volume, the rate comes down, and things usually calm down. So, I assume when you're in school you talked about regular irregularities and irregular irregularities. Do you remember talking about that in school? My nursing instructors, they just harped on us on this. So, regular irregularities. A regularly occurring pattern. Some examples are sinus arrhythmia, and there's a normal variation of the rhythm due to breathing patterns. An atrial flutter with a variable AV block. You can see atrial flutters with 2 to 1 blocks, 3 to 1 blocks, 4 to 1 blocks. Just depends on the patient. You'll have rapid atrial contractions, and some beats may not be conducted to the ventricles. PVCs are also regularly irregular with consistent patterns. You'll see extra occasional beats occurring at predictable intervals in a normal rhythm. How many of you guys drink a lot of caffeine? How many of you feel the flutter in your chest once in a while if you drink caffeine? Most likely those are PVCs.
It's fine.
Most PVCs don't cause problems, but. So irregular rhythms, there's complete disorganization. They're erratic. Causes can be from electrolyte imbalances, medications, alcohol use, smoking, stress. Examples are atrial fibrillation, where the atria just quiver, and this can lead to mural walk clots, CVAs, and MIs, which we seem to see a lot around here. So, sinus arrhythmia. Rate is typically normal, 60 to 100. It's an irregular rhythm. Your P to P intervals are variable by more than 10%. P waves are typically present, and they usually precede each QRS complex, and they're usually rounded uniform. Your PR intervals typically are normal, your QRSs are normal, and there's always a T wave that follows each QRS. This is just a variability based on breathing, and we see this a lot of kids. teenagers, kids that are growing, we see a lot of sinus arrhythmia. We occasionally will see a sinus arrhythmia in adults, but not so much as normal. Typically it's kids that will see it in. Questions about sinus arrhythmia? It's not typically going to cause any problems. Atrial flutter. Regular but rapid atrial contractions leading to a fast then organized heart rhythm. EKG findings are regular rapid sawtooth F waves at a rate of 250 to 350 beats per minute with a normal ventricular rhythm. So instead of an atrial flutter or fib where your atria are just quivering, a flutter is they're beating very, very, very fast. And that's what causes the sawtooth waveform on the strip. So this one right here would be a 3-to-1, an atrial flutter with a 3-to-1 conduction abnormality. PVCs are extra ectopic beats, most commonly in ventricular dysrhythmias, or it's the most common ventricular dysrhythmia. People may have them and never realize them. They typically don't require treatment. If they occur more than 20 to 40% of all beats, it can lead to lethal arrhythmias. It can be multifocal or unifocal. You guys know what that is? Multifocal means that they're coming from different foci. Unifocal means it's usually one foci causing the waveform to look the same. I would call these unifocal PVCs because they look the same. Can occur as a single beat, a bigeminal beat, trigeminal beat, or couplet. So that means you can have a PVC every other beat, a PVC every third beat. You can have two PVCs together, which is a couplet. The new definition is of VTAC or run of VTAC is more than 3 PVCs together. When I was in school, PVCs of 3 to 8 together was called a salvo. It sounds like they don't teach that anymore. So the new verbiage is if it's more than 3 PVCs together, you have a short run of VTAC. There's probably something going on that needs to be addressed. PACs can be difficult to identify on scripts because a lot of times a PAC will look like a normal conduction beat. It's very common, regularly irregular rhythm, may worsen with stress, typically are asymptomatic. Again, if they're symptomatic, treat the causes. I have rarely ever seen a PACs cause people problems. Usually there's some other problem that's causing an issue, not the PACs. But they can occur from stress, smoking, caffeine, alcohol, or meds. So, but they can be, you look at those two PACs, they look like regular beats. But number one, they're not regular. Number two, your P waves are peaked, and they're not symmetrical like your other P waves and the other beats. Atrial fibrillation. So the top is what a normal strip looks like. The bottom is atrial fibrillation. The tracing shows tiny irregular fibrillation waves in between the heartbeats. It's irregular, erratic. P waves are typically absent. Rhythms irregular, and most likely is atrial fibrillation. It's the most common atrial arrhythmia that we have, that we see. We see this all the time. You guys see this all the time. So the hard part with sometimes with atrial fib is that if you have a lot of electrical artifact, sometimes atrial fib can look like atrial flutter. So it's hard to tell sometimes. So ventricular dysrhythmias. PVCs, ventricular escape complexes, VTAC, VFib, and asystole. So ventricular tachycardia. Rhythm in which 3 or more PVCs arise in a sequence of a rate greater than 100. It can occur in short bursts or can remain sustained. If it's sustained, your cardiac output will eventually go down to nothing and they will code on you. So you do not want people in VTAC very long. Why QRS complex is usually greater than 0.06 seconds. It's an irregular rhythm, although a lot of times it will look regular. May have sawtooth or zigzag pattern, can be poly or monomorphic. Same way as multifocal or unifocal PVCs. Polymorphic means different foci are causing it to look different. And so if it's monomorphic, so I would say this would be monomorphic, but that together is polymorphic. because you have two different wave descriptions. Caused by factors such as heart disease, electrolyte imbalances, certain medications can be lethal if not treated. And it can be very lethal very quickly if not treated. Ventricular tachycardia torsades de puentes can appear as VTAC, but as you can see, the twisting patterns, that's where the torsades comes from, is a twisting pattern. I kind of think of it as a tornado. You know how you see tornadoes drop out of the sky and they twist and turn and get wider and narrow? That's kind of how I look at it with torsades. The twisting pattern on the ECG where the QRS complexes appear to rotate around baseline. Prolonged QT interval, if untreated, can lead to VTAC or VFib, which is lethal, and can be triggered by low potassium or magnesium. However, typically with torsades, we see it with a low magnesium. So when we see these magnesium levels of like 1, 1.2, that always makes me a little nervous. I always wonder what their heart's thinking. VFib. Now, you can look at this one and you could almost consider that, is it torsades? Because it is twisted a little bit, but technically it's VFib. Ventricular fibrillation is a lethal rhythm. Occurs due to multiple weak ectopic foci in the ventricles. Coordination between the atrium and ventricles are absent. Impulses are initiated by multiple ventricular sites, automaticity. May be coarse or fine, indiscernible rate, and very unorganized, no P waves. This is a lethal dysrhythmia within minutes. You in VFib more than 2 or 3 minutes, you're gonna, unless intervention is performed with a counter shock, you're gonna probably die. Idioventricular escape rhythms. The AV node initiates as a pacemaker due to a failed SA node function for reasons, who knows. It's usually, that's supposed to be 20, not 2. A rate of 20 to 40 beats per minute. It's a regular rhythm with widened QRS complexes, may or may not have P waves, caused by electrolyte imbalances, AV blocks, SA node dysfunction, medications such as beta blockers and calcium channel blockers. Typically it's not life-threatening, but you can get pretty sustained and significant bradycardia sometimes with idioventricular rhythms, so you kind of have to pay attention to those symptoms. And this one we all know and don't ever want to see. If you see asystole, it's a bad day. And this is a bad day too, except for the fact that it looks like they have a normal rhythm. PEA. So I think the brain plays tricks on us when we have somebody in PEA, because I don't know how many times where I've worked a code and we've got to the end of it and they're in PEA and we haven't had a pulse for a long time, and I'm sitting there feeling their carotid pulse, and I'm looking at this monitor and I swear to God I feel a pulse. Well, it's your brain playing tricks on you because you're feeling your own pulse. So realistically, listening to the apical pulse with a very good stethoscope or using ultrasound to actually visually look at the heart to see if it's beating are the best ways to confirm you do not have actual mechanical pumping function. This is usually caused by trauma, metabolic issues. You are clinically dead, period. You can try epi, you can try atropine, but it's probably not going to do much of anything. So, now we're going to name that rhythm. So I want to kind of go through these. We only have a few more minutes, but I'm going to go through these and kind of go through how I look at a strip when I look at it, and not just say, oh, this is what it is. So what's the first thing that we're going to do when we're looking at a strip? We're going to ask ourselves, is it regular? Do the R to R intervals map out? In this case,
Yes.
yes. What's the rate? So what do you think the rate is just based on by looking at it? It's hard to figure rate up when you're
Greater than 100.
yeah, quite a ways away. So you've got a 6-second strip, 1, 2, 3, 4, 5, 6. So if you count the PR or the R to R, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 15, 16, 17, 18, 19. So the rate's about 190. That's trucking right along. Are there P waves? It's hard to tell. If there are P waves, they're buried in the T waves, and it's beating so fast I can't tell. Are you able to establish a PR interval?
No.
No. Do you have QRS complexes, and do they look normal?
Yeah.
I would say so. They're narrow. You have appropriate deflection. And do you have T waves? Yeah, it looks like you have T waves, but they're kind of compressing into each other. So what would you say this rhythm is?
Probably SVT.
I'd call it SVT. Now, me personally, I know typically if they're not, really sick or having problems, and we'll give adenosine. Sometimes adenosine will break this. I like adenosine to use it. What happens is adenosine will pull out the intrinsic rhythm of actually what's going on, so you can see, are there P waves, is there a PR interval? Slow it down long enough that you can kind of see that before it goes back into the SVT rate. Sometimes adenosine will break it, sometimes it doesn't. Have any of you given adenosine before?
Not recently.
Knock on wood. Yeah.
Be ready when you give it.
Because their heart stops.
Because their heart
essentially.
stops and they feel like they're gonna die. And you have to legit give it fast. Because its half-life is just like that. So, but I like using adenosine when I need to, because it tells me more information that I can't tell by just looking at that. That's just me. Top rhythm. Is it regular?
No.
Okay.
The P.
Do the R to R's map out?
No.
Very regular.
What's the rate?
80.
80.
By 80. Are there P waves?
Yeah. There's a couple of.
Yeah, I'd say there's P waves.
Oh, we're looking at the top one. I was
Yeah,
like-
top one, sorry. What's your PR interval? Well, you've got 1, 2, 3, 4, so
Can't see that.
0.08. So your PR interval is normal.
There's PACs.
QRS complexes you've got, they're narrow, they're upright, proper deflection. Do you have T waves?
Yes.
Pretty much. So what would you say that is?
Sinus arrhythmia.
Nope.
Well, I guess
And I'm not trying to trick you either, just so you know.
Those are the two that I always struggle with. Is it a sinus arrhythmia or is it a normal sinus with PACs?
It's normal signs for PACs.
There you go.
The thing you have to look at, number one, is these two complexes are narrow. So, and if you look at the P waves of the normal beats, they're symmetrical, they're upright, they're consistent. If you look at the P waves of the PAC, they're sawtooth and upright, and they're shortened. So that's how you can determine that those are PACs. So that's normal sinus rhythm with PACs. That's why I'd say that PACs can be sometimes difficult to see. That's where it's important to measure your R to R intervals, because that will give you a clue that something's not right, because you may have R to R's marching out, and then you get to one that's like narrow, and then they march out and then narrow. That kind of gives you a good clue that you have a PAC that's in there. Bottom one, is it regular? No, I wouldn't call it.
Scary.
Yeah, it looks scary. What's the rate? Can you figure the rate? I mean, it's fast. Can you see P waves? No. Do you have a PR interval? No, you can't see it. Well, how about the QRS complexes? They're widened. They're polymorphic. What would you say that is?
Maybe fifth?
Anyone?
Polymorphic VT.
Yeah, that's polymorphic VTAC. This is a little slower rate of VTAC, but that's still VTAC. That's still classic VTAC. All right, is it regular, the top one?
No.
Can you see P waves?
No.
Do you have a PR interval?
No.
Do you have QRS complexes?
Yes.
Yep. Can you see T waves?
No.
So, what does that tell you about this rhythm?
PACs.
Atrial fib, absolutely. Now we say that's atrial fib with a controlled rate, or atrial fib with a normal ventricular response. You know, it can't just be AFib anymore. All right, how about the bottom one? This was a little tougher. Is it regular?
No.
What's the rate?
60.
About 60. Do you see P waves?
Yes.
Now, what about the PR interval?
And there's
Longer,
a P
longer,
that's missing
longer
a
drop.
Q or S.
What did you say?
Longer, longer, longer drop.
Yep. So what is that usually indicative of? Indicative of?
Winky Bach. I don't remember which one that is, but it's a Winky Bach.
Winky Bach. It's a
We get
winky
the
Bach.
type 1 in there.
You'll notice, yeah, type 1. You'll notice your PR interval gets longer, drops a beat. Normal, longer, drops a beat. That's classic Winky Bach. Top one, is it regular?
No.
Nope. What's the rate? The R's obviously don't map out. What's the rate?
100.
Yeah, probably. Do you see P waves? So if you don't see P waves, you don't have a PR interval. What about your QRS complexes?
Yes.
Yep. Do you see T waves? That's really hard to discern. What would you say that is?
Feet flutter.
Yeah. And that was a tough one because there's variable conduction rates on that one. There's some 2 to 1s, there's some 3 to 1s, there's some 4 to 1s. So something in the SA node is not happy. How about the bottom one? I'm not even going to make you go through this because you know what that is.
Is that monomorphic feedback?
Yep, sure is. Very, very uniform. That's a pretty classic definition of monomorphic VTAC.
So if you were gonna shock that, how would you do it?
Clear!
Would you sync it?
That's a good question. Would you do synced or unsynced?
I ain't poking no buttons. That's the provider's job.
Well, so what is something, all right, so say you go to a patient room and you see this on the monitor, and you're assessing the patient, and they're awake, and they're talking to you, and they tell you they feel this flutter in their chest, and their blood pressure's, let's say 100 over 70. What would you do for it based on those vital signs?
Call you.
Touche.
Dave, I think you might want to come down here.
But how would you consider treating this?
Would you have them do the vagal?
Not this one.
Not this
I mean,
one?
I would probably shock without syncing it. But I feel like Lauren asked, so you should probably sync it.
Because they're awake and they're technically not unstable yet, you could sync it in cardiovert.
Yeah, your one risk, and it doesn't happen very often, but your one risk if you don't sync a monomorphic VT like that is you could change it to torsades.
Mhm.
So
Yeah, the R-on-T phenomenon, have you heard of that?
Yeah.
if you can sync it, which that you could easily sync because it can easily match up to it,
Yep.
it's safer to sync.
Yeah.
Versus the poly.
Well, versus not syncing, because when you're not syncing, that means that it's just gonna deliver the shock, period. It doesn't care at what point it's shocking, it's just gonna bang it.
And it
If
might
you
jump
sync
into
it, it's gonna hit it right at the top of what is supposed to be the QRS, and you'll have better luck.
So you think your deciding factor would be whether or not they're stable at that moment?
Exactly. You go in the room and they're unresponsive and you're gonna shock them.
Yeah.
Period.
They're
not gonna-
unconscious, they don't
You're not
care.
gonna worry about syncing, you're gonna shock them. But people can be fairly stable in VTAC for a little while. Eventually their heart's gonna run out of gas, but you know. Top one's pretty easy. Yeah, and I'd call that fairly coarse VFib. All right, bottom one, is it regular?
Looks like it.
Looks like it. What's the rate?
30.
Do you have P waves?
Inconsistent.
So, are there P waves before all QRS? So that already tells you there's a problem. Do all P waves look the same? I would say yeah. How are your QRSs? They look, I mean, maybe a little wide, but not bad. Do they all look the same? Yeah. Do they all follow a P wave?
No.
Nope. Do you see T waves?
not consistent.
I do not. So what rhythm do you think that is based on those descriptions that you just found in this rhythm?
It's not a,
It's not a
Third
third,
degree?
is it?
It's third.
yeah.
Because of this, your P waves in your so your atrium and your ventricles are not meeting. They're completely separate from each other. There's no synchronicity between them. So your P waves are marching on their own, your QRSs are marching on their own. And sometimes your QRS is falling on a P wave, sometimes it's after a P wave, sometimes before. That's how you discern a third degree block, is that they're completely disorganized from each other. So this person probably is going to need a pacemaker, most likely. Medication is not going to fix this.
Get him out
So
of here.
you
Yes. This would be get them out.
Like
Because,
yesterday.
yes, we can put on a transcutaneous pacer, but they will not like us.
Yeah.
Especially if you have to turn the milliamps up pretty high. So you will want to sedate them if they will tolerate it. And what about this one? And I'm not trying to trick you.
It's about 80 beats.
It's sinus. I wanted to see how many people say PEA. It could be PEA, but it's to me it's too fast for PEA. So that's just normal sinus rhythm. And that's it. Any questions, concerns? These are some online resources that if you want to do practice with ECG or EKGs, you go on, there's quizzes, there's tutorials, if you're interested in looking up any of that kind of stuff. But
Can you send out your PowerPoint?
yes, I'm gonna get it to Haley and get her to put it out, so. My problem is that I built it on my home computer, and now the file is too big that I can't email it to myself, which drives me absolutely insane.
You'll have to get on remotely and put it on a
Yes.
shared folder.
So, I'm gonna log in the system remotely, and then I can put it on the shared drive.